Hello everyone. Today we will be presenting Communication, COVID, and Complications. My name is Alejandra Romo and I'm a junior in the Communicative Disorders and Sciences program. I am thrilled to be a part of the Lurie College Showcase once again and be presenting alongside my amazing partner and hear what other students within the department and college have learned during the course of the semester.
Hi everyone, my name is Aminah Sheikh and I'm also a junior in the Communicative Disorders and Sciences program. I'm excited to once again have the amazing opportunity to be presenting in the Lurie Showcase. Both me and my partner have interest in the speech medical field and dysphagia, so we are looking forward to sharing everything we learned about these topics this past semester with you all.
Last semester, we analyzed a speech sample and talked about a child's language development with a stutter. As we deepened our knowledge this semester, we want to apply our knowledge to a broader and more prevalent topic we have been living in. This time, we will discuss a matter that we have lived and in reality feared. COVID-19 did not discriminate against anyone and would pursue anyone at any given time. Today, brought to you by the Pfizer vaccine, we are making connections from our learning about dysphagia, swallowing anatomy, and treatment and management, and how it directly relates to the effects of COVID-19 on patients.
Our project is going to go over what the respiratory system goes through once COVID enters a human body, and if escalated can lead to the need for being placed on a ventilator, the hardships of dysphagia, and the overall role speech-language pathologists played this past year in providing vital care to help patients return back to a healthy state. We will also discuss how the speech pathology field looked different because of COVID, and how the role of speech-language pathologists were affected. While we still have so much more to learn, this past semester we were able to analyze the critical state our country was in due to this virus and learn about how SLPS worked directly on the front lines and played major roles in rehabilitation. The work done by SLPs with COVID patients have created admiration for the field and emphasized the prevalence of speech-language pathologists in our daily lives. I am sure we have all heard endless amounts of information and research about COVID-19 this past year, so I won't spend too much time discussing something we all know lots about. But I do want to give a quick overview of the virus before we dive deep into the bigger picture. So, COVID-19 is a virus that affects your entire body, and it is common to feel some physical symptoms if you contract the virus. Some of these physical symptoms include a fever, body aches, a cough, chills, and even loss of appetite and smell. More severe symptoms of the virus include pneumonia, neuropsychological and cognitive problems, and dysphagia. If an individual of any age has a certain underlying medical condition, this could increase their risk of severe COVID-19 symptoms. What we want to get into today is how this virus specifically affects the respiratory system and how in turn that affects an individual's swallowing. COVID-19 is a respiratory disease, and like other respiratory illnesses, COVID can cause lasting lung damage. Because of how recent this virus is, we are learning more about it each day and still understanding more about how it affects the lungs during acute illness and afterwards. But what we do know is that for mild and moderate cases, the infection travels through your respiratory tract, and as that happens, your lungs and airways swell and become inflamed. This can start in one part of your lungs and spread. This disease can also cause lung complications such as pneumonia and, in most severe cases, acute respiratory distress syndrome or sepsis, which can cause lasting harm to the lungs and other organs. To understand the damage it does, we first need to understand the anatomy of our respiratory system.
The virus that causes COVID-19 enters your body when it comes into contact with the mucous membranes that line your nose, mouth, and eyes. That's why we were told to wear a mask and to make sure it covers not just your mouth, but your nose as well. While researching, I found the explanation to this significantly easier when I was told to think of my respiratory tract as an upside-down tree. Let's just think of a cherry blossom, for example. The trachea is like your trunk, and then there's a bunch of little branches, all connected to your lungs. At the end of the branch in a cherry blossom, there's these beautiful little flowers. In this case, little tiny air sacs. Those are alveoli. Alveoli are extremely important because this is where oxygen goes into your blood and carbon dioxide comes out. Essentially how we're able to breathe. Once the coronavirus enters both, your upper and lower respiratory tract are at risk. The virus now travels all the way down into your airways, and the lining of those airways can become irritated and inflamed. In some cases, the infection could travel all the way down to your alveoli, and that's when we're in trouble. If your immune system can't fight it, and then that leads to severe cases. We will be talking about critical cases, as that is where the need for ventilators arise. 5% of cases are critical, and those are the patients that had both lungs affected. When the swelling of those passageways previously discussed is so immense, it starts to fill your lungs with fluid and debris. The infection can even damage the walls and linings of those air sacs in your lungs. This severe tissue damage has caused people to need lung transplants altogether. This is not something we ever want to see. The air sacs, alveoli, fill with mucus, fluid, and other cells that are trying to fight that infection. So much fighting is going on that breathing becomes a lot more difficult. This is when people start having trouble breathing or feel shortness of breath because your lungs become more inflamed and are filled with fluid. The lungs are tired and just can't be lungs anymore, so they need an external source. This is what brings us into the topic of ventilation. What are ventilators and why are SLPs involved?
Essentially, a ventilator is a machine that breathes for you. You can think of it as an external set of lungs. I drew the image on the screen to help you all visualize what a ventilator looks like. A ventilator is a machine that connects to a tube that goes down your throat and directly into your lungs. It sits on the trachea and the air is pushed directly on your lungs. When we normally breathe, we breathe with negative pressure and the air flows in normally at our own control. But with a ventilator, the air is being blown and forced into your lungs. In relation to COVID-19, the virus causes so much damage to your lungs and causes difficulty with breathing, so a ventilator essentially allows the patient to rest and heal while the machine does the work the lungs would be doing. But even though you're being allowed to rest, having the tube in your throat can be irritating because you cannot talk, swallow, or cough well. Since a patient cannot speak while on a ventilator, communication with these patients include eye gaze, head nods, head shakes, whiteboards, and gestures. Additionally, the tube passes through vocal cords within your windpipe, and for some patients, this can cause the throat and the windpipe to become inflamed and may lead your vocal cords to not work properly. Prolonged ventilation can lead to significant injuries and possible voice and swallowing problems, which is where a speech-language pathologist comes into play. After discussing mechanical ventilation and learning more about COVID and swallowing, I learned that ventilation use was more common in the beginning of the pandemic, and more recently, the use of high-flow oxygen therapy has become more common. High-flow oxygen therapy is a less invasive alternative to other forms of ventilation, and it essentially delivers a high-flow air and oxygen blend through a nasal cannula or tracheal adapter. It is overall less debilitating to a patient than mechanical ventilation. When managing patients with respiratory compromise, the main goal is improving gas exchange and decreasing the work of breathing. I want to mention that research about high-flow therapy and other forms of ventilation used for treating COVID is still going on, but high-flow therapy is being used more commonly as it doesn't leave patients as helpless and can reduce the duration of ICU stay. I also want to mention that the type of oxygen therapy and ventilation a COVID patient receives really just depends on the supply and resources of the area they are in. So while here in the Bay Area, high-flow oxygen therapy may be more common, mechanical ventilators can be more commonly used somewhere else. I'm mentioning this because we will be going on to discuss how swallowing is affected by invasive ventilation, usually mechanical ventilation, or severe patients on high flow.
For those patients that are saved by ventilators, this does not mean the road to recovery is easy for them by any means. COVID recovery has many different factors and parts, but today we will be discussing post-extubation dysphagia. Those are two very big words that I too would not have a clue about if I wasn't in Dr. Casella's class. So I will explain. Dysphagia is the medical term for having problems swallowing. After a prolonged period of intubation, it leads to more than 50%, 56% to be exact, of patients developing dysphagia. Later in the presentation, Aminah will go on to discuss the three main categories of rehabilitation services that SLPs provide to COVID-19 patients who require mechanical ventilation, and one of them is swallowing. Rinki Desai, a speech-language pathologist at the University of Mississippi's Medical Center, discussed just how this treatment begins. She says, We start patients with swallowing ice chips, then gradually get them to the point where they can eat by mouth. We make sure that they are safe with efficient swallowing. We also help them with respiratory swallowing coordination. While it's not expected that patients are able to eat full meals right away, the main target is to build back the comfort by being able to swallow solids and liquids again. This allows the muscles to start working again and restore the coordination of swallowing and breathing to regain function safely and efficiently. It becomes a use it or lose it matter. The best way to describe dysphagia after intubation is like riding a bike. When you learn how to ride a bike, it's a done deal, and that's a skill that's under your belt moving forward. When you take a while and you're not riding anymore, you are bound to be rusty and uncoordinated. After practicing, your muscles just remember how to do it again because of muscle memory. To give a visual of what I'm about to explain, I'm going to play a video of how food is supposed to go into our bodies, which would be an example of a healthy swallow. After, I will show you what we are at risk of with dysphagia. What we are seeing in the disordered swallow is food trespassing into the airway. You know the moment when you hear food went down the wrong pipe and somebody coughs tremendously because of it? That's because your system is trying to expel the bulgus or liquid from a place it shouldn't have been to begin with. Having a healthy swallow is vital because if not, the patient is at risk for choking, pulmonary aspiration, and simply not getting enough nutrition since they're not able to swallow. If you think about it, without a normal swallow, it begins a chain of problems that will only cause more and more damage to somebody's way or quality of life. While being on a ventilator, you will not be able to swallow because you won't be eating. You will be receiving nutrients through a different tube. When removed from that endotracheal tube, some patients report having difficulty with their swallow. This can be because of many different factors like direct trauma to the anatomy of the throat, so your vocal cords, tongue base, epiglottis, or arytenoids by the endotracheal tube. There could be muscular weakness due to the nerve and muscle damage, or the loss of normal sensation in the larynx.
Speech-language pathologists are providing essential rehabilitation services to patients recovering from serious cases of coronavirus. I want to go into a bit more detail of the specific treatment and rehabilitation services speech-language pathologists are providing to COVID patients recovering from debilitating ventilation and the various symptoms of the virus. Since each treatment varied by individual, the topic of rehabilitation is unique to each person and overall a broader topic. But because of that, I broke up treatment into 3 parts: swallowing, communication, and cognition. The first part is swallowing, where an SLP will evaluate a patient's swallow and provide treatment to strengthen the tongue and swallowing muscles. To evaluate a patient's swallow, the SLP will give the patient different types of food, varying by thickness and texture to see how they swallow and where their starting point is. A thin liquid like water is harder to swallow because it moves very fast in the mouth and splashes down the throat. A thicker liquid like applesauce moves slower and allows more time for parts in the throat to react and cover the airway. While the patient swallows, the SLP observes the person. If they notice that the patient has food in their mouth after the swallow, this could mean they have weak muscles and less sensation in their mouth. This could also mean that they are at risk at choking on the leftover food in their mouth. If their voice quality changes after each swallow, this could mean food or liquid is going into the airway. And lastly, if they cough before, during, or after the swallow, this could mean food or liquid is going into the airway. This evaluation is very important because for swallowing, a speech-language pathologist's main goal is to make sure that the patient is safe and can return to efficient swallowing. The second part of treatment I want to discuss is communication. For patients that have spent a period of time on a ventilator, either communicating through alternative augmentative communication methods or even communicating little or to not communicating at all, they need to work on regaining their voice and communication skills. Speech-language pathologists use voice therapy techniques and exercises to help their patients get their voice back as soon as possible. Finally, the last part of treatment I wanted to mention is cognition. After a prolonged period of ventilation, patients can come off ventilation disoriented and feeling lost. An SLP will help these patients regain function if patients have trouble with memory, orientation, attention, concentration, and problem solving. Through rehabilitation, various therapies, activities, and techniques individualized to each patient can help them return to a healthy state after battling the virus.
SLPs were in the front lines during the pandemic as well. As we heard of and were very alarmed by early on in the pandemic, there was a shortage of personal protective equipment. This impacted hospitals severely and differently all over the globe. While doing research, I found that the University of Mississippi's Medical Center wrote an article expressing all the challenges they faced. Choices had to be made determining who the limited resources should go to. The most obvious answer would be the critically ill. But how many did we hear were critically ill? Thousands, and hospitals were overflowing and had zero space. Professionals who could go into these patients' rooms were limited because of the lack of equipment to protect themselves. Pulmonologists, the ICU physicians, and the ICU nurses were the ones that just had to be there. The rehab professionals, including SLPs, had to stand back and couldn't see patients, sometimes until they were COVID-19 negative. This plays a significant role in how long a patient stayed in the ICUs. In not receiving the rehabilitation services that SLPs provide, it increased their stay. Ms. Desai even states that for every day a patient is in the ICU, the patient is bedridden and deconditioning, so it takes about a week to recover function. Matters were quite different closer to home. Professor Castillo talked to us about how different the experience of SLPs was in Santa Clara County compared to other regions, like the University of Mississippi, and everything they explained in their article. If I were to compare experiences and struggles from many different places, we would have a plethora of different situations to talk about. Every setting, every hospital was different. SLPs had to see patients in the ICU and in recovery. Everyone, as in the general public, was advised to wear a mask that was tightly secured around your mouth and nose, but SLPs were unable to do so. Treatment sometimes involves the SLPs modeling certain facial movements and exercises, therefore your mouth could not be out of sight. They turned to face shields to make sure that they could provide proper care while still protecting themselves. Since the beginning of the pandemic, the shortage in PPE in some areas has looked up. SLPs now have the tools they need to stay safe and assess their patients. They are now able to begin therapy as soon as possible in attempts of minimizing that deconditioning and weakness we talked about. Pre-pandemic functioning for all patients seen during this time is the end goal. Everyone deserves a voice is a slogan we hear a lot in the SLP field and really states their purpose. After experiencing this pandemic and seeing what professionals in the field had to overcome, it makes me think everyone deserves a voice, even when yours is shaky with fear.
We want to thank everyone for taking the time to listen to our presentation and deepening your understanding of this complex topic. It is so rewarding to be working towards a field that provides such valuable care and services to everyone.
We were thrilled to present this project to everybody here tonight. Thank you so much for joining us. It's starting to feel like there's light at the end of the tunnel, and what our healthcare heroes endured is something to applaud every day.
We want to give a special thank you to Professor Castillo, who helped expand our knowledge of this topic throughout the semester and provided an insight of what it looked like for our speech-language pathologists when facing a pandemic.
Also, a special thank you to Dr. Casella for guiding us with our topic idea and helping us to think critically about all the concepts discussed tonight. Also, without Dr. Lustigman's ideas and feedbacks, there would not be a presentation tonight, much less one that showcases all of this information clearly.
Thank you.